everyone. My name is Vanessa Blumer. I'm an advanced heart failure and transplant cardiologist at Innova Heart and Vascular. It was an honor to be able to chair this American Heart Association scientific statement that we will be discussing today.
Hi, everyone. My name is Manreet Kanwar. Like Vanessa, I'm also a heart failure cardiologist, although I practice in Pittsburgh, Pennsylvania.
Manreet, why don't we begin by discussing why we focused on cardiogenic shock in older adults for this scientific statement?
Sure. So, Vanessa, as you know, cardiogenic shock, despite all the recent influx of information, randomized control trials, and other research that's being done on the topic, unfortunately continues to have a very high mortality, nearly 30 to 50%, depending on where you're looking. Patients who present with cardiogenic shock end up dying during the index hospitalization. Now, of course, survival itself is dependent on many, many different factors. Why they are in shock, how sick they are when they first come in, what is done to treat them. But one thing, specifically in this case, age plays a crucial role in predicting or sort of having a risk assessment profile on how they will do. And as we all know, age is a non-modifiable risk factor. And regardless of how they present compared to their younger counterparts, older patients continue to have higher death rates in the hospital, regardless of why they are in shock and how sick they are when they first come in.
I think on top of that, it's not just that cardiogenic shock is more common in older adults and that obviously it's highly prevalent, but perhaps more importantly, I think that like you pointed out, age significantly influences treatment decisions in this patient population, particularly regarding invasive procedures and escalation of care. For instance, while heart transplant centers often have age limits for patients, the criteria for older adults to receive durable left ventricular assist devices varies widely between centers, and some still reference age as a limitation for patients to receive LVAD.
And sure, at some level, I understand why that is. And yet, when we look at other clinical presentations, so let's say patients who have a heart attack, may not necessarily be in shock, patients who have severe valve disease, even if those illnesses are presenting at the same age profile, the very elderly, let's say octogenarians, nonagenarians, their outcomes have actually started to improve and mirror those of their younger counterparts. But we haven't necessarily seen that mirrored in cardiogenic shock patients. Now, part of the problem, of course, is that these patients, these extreme age groups, are often not included in our clinical trials, so they're not represented in the data that we seek to see how we can improve their outcomes. So this unfortunately leaves us with a significant knowledge gap in this area, so we don't really truly understand, is it age alone or is it something else that's driving their higher rates of mortality during hospitalization?